Thank you.
Yeah, thank you. So my name is Mary Douglas Smith. I am a pharmacist. I am on the board of pharmacy, and I am the director of experiential education and an assistant professor of pharmacy practice at Presbyterian College in Clinton. I remember that from this summer. And so I am happy to be here today. I really appreciate this opportunity to speak with y'all and hear the other testimonies. I do have an opening statement prepared. I'm going to reduce it very short. So we as pharmacists are guided by three principles: the law, the professional code of ethics, and evidence-based standard of practice. With every prescription order received from a prescriber, we balance the risk, benefit, and patient autonomy in being the dispenser of this medication. We are not simply vending machines that deliver medications to patients. We have received more than 6 years of education and training in medicinal chemistry, pathophysiology, pharmacokinetics, genomics, and therapeutics. Our clinical reasoning skills started in school and have been refined over years of practice, influenced by our experience, intuition, and knowledge. We look for guidance from many sources: the evidence-based literature, the FDA, the CDC, and even our state agencies like DHEC. The South Carolina Board of Pharmacy, by statute, relies on a pharmacist's professional judgment, and to date, there has been no board discipline against any South Carolina pharmacist related to the decision to dispense or not dispense an off-label treatment for COVID-19. Just as doctors have a physician-patient relationship, we pharmacists have the triad that includes the relationships between ourselves, the prescriber, and the patient. We value this triad to keep the open communication with each of the parts to make the best, most informed decisions for our patients. I'm happy to answer any questions.
So I do have one question. So
Sure.
if the doctor from Spartanburg, he writes a prescription for ivermectin, it comes to your pharmacy, how do you handle that?
So there was some guidance.
Excuse me. He writes a prescription for ivermectin to treat COVID-19.
Okay, thank you. I have not typically seen river blindness in my practice either, so I would assume it is for that. Earlier this year, throughout the pandemic, there were 39 boards of pharmacy, including our own here, who released guidance to pharmacists when receiving these types of prescriptions. Use professional judgment, consider the amount of medication dispensed, and verify a diagnosis prior to dispensing. That was not to prevent or inhibit, and this joint guidance was issued by both the Board of Medical Examiners as well as the Board of Pharmacy in March 2020, and has been rescinded effective of June 2021 when the state of emergency was lifted. So to answer your question more clearly, I would still follow a similar guidance from that. If I was a retail pharmacist and I saw that, and I am, and I saw that prescription come in, I would talk with the patient about why they received it. I would look at the quantity prescribed. I have seen some of these scripts have been very high quantities, 100, 200 tablets. Of course, that does deplete my supply on the shelf, and so I have to consider that as well. Dispensing to one patient means not giving it to another. And then I would also call the doctor and just verify the diagnosis. I have a corresponding liability as the dispenser of that medication. It's got my license number on it. And so I would want to make sure that I understood the diagnosis and the reasoning for that prescription.
So when you call the doctor and the doctor gives you the reasoning, whether it's 50 or 100, whatever,
Sure.
and the patient says, thank you, thanks for calling my doctor, thank you for talking to me, do you fill the bottle with 100 and hand it to him?
If I thought that it was the best course of treatment for that patient and I was able to supply their needs, I would make that decision.
Let's say you've got 400 million pills on there and you couldn't even you have too many pills and you're trying to give them away. Are you going to override that doctor after consultation with the doctor?
Override and not fill?
Yes. Could that happen?
It could happen, yes, sir. I can give you an example of that. When I was working in retail pharmacy full-time, this was like 2010 or so. I would often see prescriptions for oxycodone, 30 milligrams, more than 300 tablets. It was a valid prescription written by a valid doctor, but I felt very uncomfortable giving one patient that many oxycodone tablets. And so,
And why did you feel uncomfortable with that?
yeah, there was a high diversion of those medications, especially in the middle of the opiate epidemic. In many of those instances, it was not a patient or a prescriber known to me. And so the patient might be from Kentucky, the prescriber in Florida, and they're here in South Carolina to fill it. I felt like the risk of having 300 oxycodone tablets to that patient and in our community was not worth the benefit.
And is that based off of what you know that those pills have done to people over the years?
Absolutely. Experience and intuition.
All right, and based on the testimony from the doctor from Spartanburg who said it was either nationwide or worldwide, there was 500 contributed to Tylenol, 1 for ivermectin. What would give you pause to, if ivermectin, it seems, if one person dies from ivermectin and versus 500 from Tylenol, why would it give you pause to even fill that prescription?
I also have pause filling Tylenol. I know that sounds silly, but a lot of the preparations of pain medications historically had 500 milligrams of Tylenol in it and instructions to take 1 to 2 every 4 to 6 hours, which results in more than 4 grams of Tylenol, which is toxic to the liver. So I don't know that I feel more hesitancy towards ivermectin than Tylenol, but I think I have hesitancy for all prescriptions where my primary focus is patient safety.
Right, but we're talking about ivermectin today, and I believe I could stop at CVS on the way home and buy a bottle of Tylenol and take 30 of them if that was my choice without
sure
a
could.
prescription. But I'm trying to figure out, we understand the opioid thing, and I think the Senator from Beaufort's trying to get us a different avenue to that. That's probably going to hear from him in January that
Okay.
you may or may not be prescribing sooner than later. But I'm trying to figure out what would give you pause after talking to the doctor, talking to the patient. You said you still may not feel. What about ivermectin gives you pause to not fill that prescription when you've called the doctor and you've talked to the patient?
The doses that are being written right now are high. They are less evidence-based than what we normally see for river blindness, for example. I would still be worried about side effects and toxicity.
And when you say
And
dose,
it's totally hypothetical, so it's hard to answer, based on the patient, if it was an adult versus a younger person, if they were healthy, if they had diabetes. There's so many factors that would go with that.
okay.
But that I would look at it, and I would look at the patient as a whole.
And when you say dosage, I know you said like 100 or 200. I'm assuming that's the number of pills.
Total,
And I don't know if ivermectin comes in 1 size or 40 sizes or whatever else. When you say the dose, are you talking about the actual milligram of the pill,
Yeah,
or are you talking about the number of pills?
both. So what I've seen is 3 milligrams. So it's a 3 milligram tablet. Take 8 tablets twice a week. That would be an example prescription.
Okay. But then but do you have knowledge to, like, when you said you would talk to the physician and you would talk to the patient, do you have knowledge? Like for me, if you told me to take 3 milligrams 8 times in 2 weeks, okay. I don't understand with ivermectin if it was 12 milligrams 8 times a day. I don't know that. But if you've talked to the doctor and the patient, and like we talked to the other lady, it was Dr. Cook, I believe, that said sometimes they make a mistake. Maybe he meant
Yeah.
3 milligrams 8 times in a week, but he wrote it wrong. And you've consulted and fixed that issue. But once you've talked to them and feel comfortable, what would prevent you at that point from just saying, no, I'm not going to fill this? And I'm not picking on you. I'm just saying for any pharmacist, because you're representing them right now. What would prevent somebody from still going ahead and say, I talked to the doctor, I understand what they're doing, the patient's fine with it. What would stop you from, what makes you say, nope, I'm just not feeling this at all?
So fortunately, pharmacists have a lot of access to really good databases and resources. So just like a prescriber would go in and look at the literature, we would as well. We use those same Cochrane reviews, PubMed, LexiComp, and the first thing I would go do is see the maximum safe dose of that medication, whether it be ivermectin, Tylenol, whatever. If I still thought that that dose, or I saw that that dose exceeded that maximum dose, that would probably be my biggest hesitancy.
Okay. Thank you.
Yeah, thank you.
Senator from Orangeburg.
Hey.
Are you aware of any pharmacist that's been threatened, or, you said none of the discipline, but are you aware they've been threatened that their license would be in jeopardy if they fill a prescription?
I have not, and I'm fortunate that I have a wide network of pharmacists, especially in this state. I have reached out to several, and I have not.
All right, and if you work for a chain, I call it chain pharmacy, let's say you
Yeah.
work at a CVS.
That'd be right. Mm-hmm.
Might they have protocols established at a corporate level, or is it still the independence of the actual pharmacist who's filling that prescription that determines?
There certainly could be limits, like with the opiate crisis, we saw limits on that. That there was a store policy, and so I am sure that those are out there. I don't know any specifics though.
Thank you. Senator from Lawrence.
Thank you, Mr. Chairman. Representing the 2nd Congressional District.
That's
I
correct.
believe. So Dr. Cook testified that BME has enough trouble that comes to them that they aren't aggressively pursuing. The board, are y'all meeting virtually? Are you meeting at all regularly? So
We actually met in person last week over 2 days, and
Okay.
so yeah, we are meeting regularly.
I know you can't specifically or discuss specific cases. No pending cases regarding malpractice or disciplinary action on a pharmacist regarding
Right.
any of these other off-label you've heard. No awareness of anything that the LLR gatekeepers, and I should have refamiliarized myself with the complaint process and then how it's winnowed.
Yeah,
I
same
believe
process
actually
as
an
Dr. Cook. Yeah.
Yeah, okay.
And so nothing has reached my level at all.
Okay. Thank you. Go Blue Hose, yes.
Yeah, thank you.
Thank you. I really appreciate you answering all these questions because it's, you
Yeah.
know, it helps us get an understanding of what we're dealing with and what we, versus what we get told. And
Yeah.
so I appreciate you answering all my questions and all the committee's questions. And
Yeah, happy to answer any more as the days go forward. Thank you.
Thank you. And thanks everybody for their time.